Now, okay. Recording in progress. All right. So I'm very pleased to introduce, very pleased to introduce Ali. And it's 20 years. We've known each other for 20 years.
Oh God.
Yes, I know. Isn't that awful? Isn't it great? And Ali, I said, Ali was my right hand for many years. And my favorite story about Ali was back in 2008 when Peter Biasucci from the Ministry of Health came to me and he said, I want a model of the healthcare system. And after I stopped laughing, I said, well, I've got a new PhD student. And damned if he didn't do it. Like he built a model of the healthcare system for Ontario. And it was brilliant. It was just it was a work of art. And he's continued to do much more. He's 6 years with strategic analytics at TCO and with his team and currently Vice President, Klick Consulting, spreading wisdom across the world. Anyway,
Yeah, exactly.
So Ali, please come and welcome.
Spread some more wisdom. Thank you. Hi everyone. I'm gonna just start screen sharing so that we properly record this. There we go. Okay. Thanks for coming. Thanks for giving me your lunch, and good to see familiar faces and new faces. I'm Ali. Yeah, I've kind of my path has crossed with lots of people's paths here, and it's been an amazing journey through healthcare. I think one of the things that I've been lucky enough to do over the course of kind of many years I've worked in healthcare is see different parts where health is managed, and either, you know, from a preventive perspective to a curative perspective, in private settings and public settings, in even kind of venturing into places where healthcare is completely not professional and looking at how caregivers care for people and kind of finding ways of supporting that. So what I want to touch on today was really pulling everyone's attention to maybe slightly neglected area of the data universe, which is really kind of the unstructured patient conversations and what they can do for us. And this is a talk that I adapted from a talk I gave a few weeks ago at an industry association that kind of in the United States. And it reminded me of grad school a little bit because I got drilled for hours before I could give this talk because it included the phrase real world evidence in it, which has a very specific meaning, you know, derived from very structured data, from kind of data that's collected by professionals and clinicians. And we were proposing a talk on thinking about other data sets as sources of insights, both clinical and behavioral for patients. And it was like a bit of a thesis committee meeting where they pulled me into a room. There were these industry veterans who just wanted to murder me. But we somehow gave the talk, and I'm just going to say this was the most highly attended talk. So, you know, we're invited back. But so that's kind of going to be my focus. Hopefully we can have a conversation going around this as well. So that's what I want to highlight today. Let's get started. So first of all, I work at a company called Klick Health, which no one should ever go to the website of because you will be dizzy from all the animations and not understand anything. It's a part of our recruiting process. If you can crack it, you're in. So I just want to give you a bit of background on what I do today before I dive into this. So Klick is actually the world's largest independent global commercialization partner, such a fancy phrase. But what that means is we work with pharmaceutical, medical device, and digital health companies to bring their products to market, all the way from inception, where you might be doing kind of from a medical perspective, evaluating the merits of the product, and understanding what medical strategies will yield the best product market fit, all the way to things that have come to market and they're scaling rapidly. How do we facilitate that scaling? I work with companies that are in the rare disease space, in the prevention space. I work with very kind of early stage startups, a lot of them here in Toronto, who are using things like biomarkers to diagnose disease. And a good chunk of my work is also with consumer health companies, which has been a kind of a new extension for me in my new role, which is all the stuff you find at Shoppers Drug Mart. And the idea, and it's really interesting how much of health is becoming consumerized for various reasons, and how big a role that actually plays in our broader health ecosystem. So that's a bit of what we do. The company is big; it's 1,600 people. We have offices in Toronto, New York, Philadelphia, Sao Paulo, London, and Singapore. And it's an interdisciplinary company. A huge chunk of it is actually marketers and commercial strategists, which is more on the kind of business side. But we have the world's largest medical team. We have 150 MDs on staff that work with us on kind of getting the clinical and regulatory aspects of our work right. And we, of course, have kind of various teams, such as a huge development team that builds software as needed. So it's a large company. Where I belong is a tiny corner of that large company, about 40, 50 of us in the consulting group. And it started about 5 years ago, and I joined about a year in. And the consulting group really looks at the idea of growth. So growth for a company can come from many places. It can come from new services and new products you bring to market, which facilitates growth. It might come from partnerships. So it could be, let's say you're partnering with a virtual care company to expand your reach, or through acquisitions where you are bringing new companies or products or services to your portfolio through acquisitions. So a lot of what we do is help on that growth side and understanding what services will actually and what products will drive that growth, and how can we drive that growth. So I do two things. I oversee a number of clients. So that's the kind of the day-to-day boring stuff of running those client engagements. And I run our data science and personalization practice, where we actually build solutions, be it kind of machine learning models that get embedded into products, or full-on kind of products that then our customers will bring to market that have some sort of a data science prediction component in them. Please stop me as I'm talking. It's a small group, so you don't have to wait till the end. I've been with the company for 4 years, and worked on really, really fun stuff. This slide that's very busy to give you a more kind of AI lens to what we do. I've worked on problems where we've built ML solutions to help coach people through their self-care of autoimmune disorders, where these disorders kind of manifest very differently for different people, and you really need to adjust things like your diet and lifestyle to kind of maximize the effects of therapies you're on. And it goes through, if you think about it, a trial and error process to figure out what you need to cut out and what you need to introduce to your life. So we've partnered with a startup to actually use their data to see if we could actually kind of flag those a bit earlier on. So the time from your initiation to kind of seeing results is reduced. So did some work on that. One of my favorite projects was trying to diagnose this rare disease from people's pupils, where we would simply use a cell phone to take a picture of your pupil and see if you could potentially have this disease. The fun part of that project, and I teach at IHPME, and we have a whole lecture on this, was not the data science part, but was actually figuring out what solution would actually work in the field. So we partnered with designers and built mock-ups and took it to doctors and nurses and optometrists to figure out where this solution could actually be used to detect rare disease and what would actually be used, and then use that as a way to then identify, well, then what should the parameters of this predictive algorithm be, and at what level do we need to meet? And that's kind of something I've, since that project, been trying to bring to all of my work. And we, from a personalization side, we build recommender engines. A lot of work I've been doing is in the woman's hormonal health space, which over the last 2 years has gotten a lot of attention. And that is an exceptionally hard space to navigate. And a lot of the navigation happens by the patients and their caregivers themselves. So been building solutions based on recommender engines. And of course, if I don't say it, I wouldn't be a good data science leader. Generative AI, and we have essentially a chatbot-based solution that was released in the UK that helps people navigate through polycystic ovary syndrome, et cetera. So kind of experimenting with those technologies more as an outsourced innovation lab for very large companies that find it difficult to do it in-house, with the idea that they would kind of go into companies later and adopt it. And then last thing is, this came out this week. We also do our own research, and some of that research I'm going to hit on today. This was work we did over the past 3 years. I was actually one of the participants in this. I had to wear a continuous glucose monitor for 2 weeks. But this is where we are able to detect type 2 diabetes from 10 seconds of voice recordings to classify people as kind of healthy or maybe glycemically compromised. So you can, this paper just came out in the Mayo Clinic journal, and you can see that. Okay, I'll pause there. Any questions, comments, thoughts before I dive into the main? Yeah. Sorry? Oh, maybe what you're referring to is the kind of hormonal health space. Yeah, that is extremely, it's an area that medicine has neglected for decades. And it's essentially patients have been kind of pretty much left to their own devices for all that period. So it's a space that now finally is getting some attention and require, and I don't know, we as a group feel very strongly about kind of participating in the kind of in building solutions there. Yeah. 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 Yes. Retina. Yeah. 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 I can't disclose. I can't talk about too much, but it's a rare disease. It has ophthalmic manifestations, and it's actually, the manifestations aren't in the retina, it's actually at the front of the eye. So that allows us to do that, and you don't need to do retinal imaging. Yeah. No worries. Okay. So I want to talk about real-world evidence from patient or user-generated content. Are you familiar with this phrase generally, user-generated content? It's like a professional way of saying Twitter, X, TikTok, Instagram, Reddit. Okay, so from when we're innovating for growth in health, or just innovating in health in general, I think what's really critical is this understanding the implications of this triangle that's on this screen. So this is adapted from a paper that I really like, and it breaks down the population of kind of chronic care sufferers by the kind of amount of care they receive in different settings. And the tiny sliver on the top right corner is the professional care setting, where the care is actually delivered by someone who is a clinician of some sort, or in settings like pharmacies. Everything else is care that's delivered either by the patient themselves or by their caregivers, or by their community. And in a lot of cases, a lot of our innovation work is in innovating in the professional care space to make that professional care better. However, let's say you're diabetic, or let's say you have dementia, or you have depression. A lot of the care actually happens in the bigger part of that for almost all of the people, except those who are really, really complex. So it's important to understand the clinical experience of the patient outside of that just professional care sliver, and understand their needs and how those needs differ from what they need from their professional caregivers versus what they need when they're doing self-care. And self-care is a phrase that's actually more American, and That's an important phrase to know, because even though it has weird connotations now, like yoga or just self-care, self-care is actually historically meant addressing your health concerns yourself, using things like traditional medicine, over-the-counter medicine, taking care of each other, just everything else that happens outside of popping pills and getting cut up. And that journey is very important to understand. Otherwise, you're only innovating for only a sliver of that experience. If we dive into that self-care part of that triangle, it goes beyond treatment. So it's not about just taking, let's say, Advil when you're feeling pain, or you know, doing certain activities to reduce your lower back pain. But it also goes into testing. A lot of testing, for example, happens thanks to virtual care, and other providers have really kind of stepped up since COVID-19. A lot of that happens at home now, and a lot more will happen at home because of both kind of patient preferences, but also amazing improvements in testing. There are CRISPR-based testing kits that can look at 10 kind of conditions or at once with just one sample. We didn't have that before. Obviously, self-management, self-treatment is important, but the other piece that's also really important is the capacity to care. And that's kind of self-awareness part. And we, you know, again, it's not necessarily that exciting in the professional care side of things, but that capacity to care is critical. The capacity to care for yourself, but also capacity to care for others. And if we think about a population that has multiple chronic conditions, that capacity actually is learned and needs to be fostered for everything else to work. So self-care is really important, and self-care has multiple components. And self-care has no data. So this is a US snapshot of the data sets that we have on, the example here is prescription-only medicines, but you can also replace that with, various therapies. What data do we collect on the professional side of healthcare versus the self-care side of healthcare? And the self-care side of healthcare doesn't have that much data, not because we're bad people, but because there is actually a different payment and regulatory and medical context around the data that's collected for things that are prescription only or are delivered only by clinicians that requires us to collect all of this data. So everything from adverse events to patient demographics, and a whole bunch of data is collected, especially those of you who've worked in the kind of especially the Ontario health system, know how much data is collected, or when you go to a hospital, how much information is taken from you and codified. There's a reason behind that, but the same thing doesn't happen when you're at home and you're managing your diabetes, let's say, through diet modifications or lifestyle modifications. There are, for a while, especially since kind of mid-2000s until 2019-ish, apps were seen as potentially this opportunity to bridge this information insight gap, because everyone had a cell phone. That thing had lots of sensors on it, and you could just collect data that could actually help with what's happening outside of the formal healthcare system. That actually hasn't delivered on its promise yet, partly because of the approach to that had been apps trying to monetize that data, which means the creation of silos and even worse interoperability than traditional healthcare solutions. So that hasn't delivered. So there's still a gap there. Things are going to change over the next decade, but we're not there. And we have things like surveys. There's a lot of organizations that administer surveys. Some are public, like Health Canada administers surveys. There are also some organizations that have amazing panel data. I don't know if you're familiar with Nielsen. They are famous for TV ratings, but they actually have a health panel that they run regularly, where people not only complete surveys, but they take blood samples and lab tests, and it's associated with kind of their conditions and attitudes and all of that. So there's that, but that's again done on areas of interest and done not necessarily at the pace that some of these, what we might need. And then there's Twitter, TikTok, user-generated content. So we've been quite interested in user-generated content for two reasons. One is obviously this gap, because there's a promise. The other reason is it's out there and available. Like you don't need to jump through hoops to actually look at what people are talking about in the context of menopause, for example. It's this amazing landmine of data that's exceptionally messy to work with, that's there, and that's constantly there and evolving and responding to things that are happening in the world real time. But there's been some concerns about using this data for more kind of rigid clinical evidence that you might use in our process. Part of it is stemming from the misinformation and disinformation that we're all too familiar with in social platforms. Part of it is the messiness of actually longitudinally collecting that data and making sense of it. The misinformation and disinformation, or kind of nonsense that you might see, that's a very interesting area, and we looked into this. And there's actually a lot of papers coming out, and I cited a couple here, that looked at patient communities in various spaces, let's say Reddit, and looked at what happens when someone comes in with misinformation. How does that community respond? Does it amplify or does it correct? And actually, in a lot of cases, patient communities will actually correct, because it's people who are genuinely frustrated with a condition, who are trying to navigate it. And when nonsense comes into the picture, they don't have time for it. So it's an interesting kind of Wikipedia effect where people will, even if there aren't kind of obvious moderation rules in place, it will self-moderate. Will it self-moderate perfectly? No. But there's a huge pressure to actually come closer to the truth of what works, what's real, what's experienced. So that's actually a really interesting finding. The other piece that's really interested with user-generated content, again, a bit messy, but important, is emotions. Clinical notes don't include emotions unless you're being exceptionally disturbing in the clinic environment, at which point that's a note to say this patient will be difficult. Outside of that, you don't have the emotional state of the patient or the caregiver. And when we're thinking about making people's lives better, what is a better indication of things that aren't working but the emotional side of things? Because lab results will give us the kind of the biomechanical, chemical, mechanical situation that's happening, but you actually don't have the emotional piece that go along with it. And why that's important is you might be focusing on addressing X symptom in a certain way for, let's say, menopause, when actually that may not be the thing to focus on, and that may not be the thing that people are actually really worried about. Their quality of life is being significantly affected by something else. And what we know also is people are not going to readily admit that to their clinicians. And they're much more likely to talk, patients are much more likely to talk among themselves as opposed to talking with their clinicians about the emotional state or things that really worry them. So you have that rich piece of information. Yeah, so lots of opportunity here, but how do we get that out? So Marianne, I said I would give you a trigger warning. We're going back to March 2020 for a brief period in this presentation. It is going to be COVID, lots of COVID talk for a little bit, partly because that's what I can share with you. That is not privileged to my clients, but partly it's a really good example of how you can use this data for clinical insights. Okay, so March 2020, by that point, SARS-CoV-2 has been circulating since November 2019, and the medical community is trying to understand how to differentiate COVID-19 from another upper respiratory problem. Why does that matter? Isolation immediately, because this is the rapid control phase of the pandemic, or it hadn't, just the beginning of the pandemic. but also to be able to decide immediately on certain therapies that might be very effective earlier on as opposed to later on. So what's happening at this time is the medical community is trying to understand what are the risk factors, what are symptoms, what is COVID-19 versus not. At the same time, I had to walk into the office and steal all the monitors I could and take them home so that I could set up a home workspace. And so did everyone else in our company. And all our clients went dark for a bit and we had nothing to do. So we thought, why don't we actually use this time to do some kind of interesting stuff to keep ourselves busy as everything around us shut down. And one of the questions was, yeah, what is the hallmark symptom here? Is there one? If there isn't one, that's actually very interesting because that makes things much more difficult. And if there is one, that is also interesting because we can actually do something with that. So what was really neat at that point was, if you're familiar with it, Allen Institute for AI created this data set called COVID-19, so COVID-19 open research data set. And this data set was kind of routinely updated to bring in everything from case reports to study reports to various publications, et cetera, all in one place, and then semantically process it. So what that means is then you could easily kind of work with this data to extract things like, what was the patient population like? What tests were looked for? What symptoms were kind of assessed? So almost kind of like they've structured those papers to an extent for us. So the first thing we did was, great, they already did this. Why don't we look at this data and use some of our NLP know-how to see if there's any evidence for any symptom that kind of nicely differentiates people COVID-19 or not. That was one question. We also looked at other questions as well. I'm not going to touch them today, but they were around. And then what other characteristics were associated with good or bad outcomes during a hospital stay, et cetera. But I'm going to focus on symptoms for today. So we pulled this data in. There were 45 cohort-based retrospective studies. There were 13 clinical outcomes that were tracked by COVID-19. There were also a number of variables coded by COVID-19, but we actually had to expand that. So in the end, we end up with 304 clinical and demographic variables. We used a workflow that utilized Amazon Comprehend Medical to extract medical entities out of these papers and link them to these variables. And kind of looked at the question, what is a hallmark symptom, or what are hallmark symptoms? Well, it turns out there wasn't one from the literature at the time. So when we looked at the characterization of COVID-19 symptoms across papers, it was extremely heterogeneous. So a set of papers from one area would have kind of given you, these are the 5 symptoms that you see with every COVID patient. Another set of papers from another research group or case reports wouldn't even mention some of them. So what's happening here? The other thing that we found was really the symptoms that were being assessed by all of these papers and case reports were confined to typical things that you assess in respiratory infectious diseases, as one would. But what that means is you're limited by what you looked at things in the past. And there might be symptoms outside of those measurement instruments that could be relevant that you wouldn't pick up because you're not looking for it. Or you may have seen it, but you're not going to record it. So then what we did is we said, okay, so that didn't work. And we then pulled Twitter. So we looked at the same time period, November to, was it November? Yeah, January to March 2020. And we found people who had indicated that they had COVID-19. And there were various kind of logic rules we used to declare someone as having COVID-19. And then we pulled their tweets. And to kind of augment what we found out through the literature. And what that gave us was interesting. So we had our literature data set, which had around 116 papers and 304 clinical attributes. And then our Twitter data set had over 1,000 users, roughly 80 tweets per user, and 51 symptoms that were mentioned in those tweets throughout the kind of COVID-19 journey. So we expanded the symptom landscape with social media data, and we characterized symptoms into 3 categories. Some symptoms were rare, so only, I believe, less than 1% was our threshold. Yeah, around less than 1% are rare symptoms, 1 to 10% were less common, and anything above 10% we identified were common symptoms of COVID-19. The nice thing you can do is, of course, you can see these symptoms longitudinally. You can see when they pop up and pop back and disappear. But the other nice thing you can do that you can't do from aggregated study data is you can look at clusters of symptoms. So, for example, we were able to see there was this diagram is annoying, but essentially what we're able to see is, symptoms don't necessarily occur in the same clustering. There are people who have kind of this like GI cluster who had stomach and bowel issues with other upper respiratory issues. And there was a whole bunch of people who never had GI issues, but they all kind of had COVID-19. When you're bringing data together from papers, you can't do that because you don't have patient level data unless that's shared. Now, what was the next slide is the thing that is the reason why I'm talking about this work, is then we brought together the overlaps and said, okay, so what were the symptoms that we found through medical literature? What were the symptoms that we found through Twitter? How much of it overlapped? And what was novel in user-generated content as opposed to what was being reported by case reports? So there were, of all the symptoms in our symptom universe, 25 were novel symptoms that were only mentioned in social media and had no mentions in any of the clinical reporting by March 2020. So this is super early in the pandemic, and 8 were only mentioned in literature. What was really critical is one symptom that was a common symptom in social media that hadn't been mentioned in literature, and that was the loss of smell and taste. A lot of people talked about how they can't taste anything and how they can't smell anything. And as we know now, that was a hallmark symptom of that variant at the time. Not necessarily, there were people who did not have that symptom, but that was a very common symptom that we saw in COVID-19 infections in that first wave. Like I said, loss of smell or taste is not a common thing that we record in our medical instruments. So it did not show up in the case reports, but it was loudly showing up in social media. I don't know if you've seen this, but after the fact, there were a few groups that started tracking various COVID waves based on Amazon reviews of candles, scented candles, and it perfectly followed the various waves in different geographies, because people would just write scathing reviews of candles that did not have any smell. And you're like, oh, there's a wave there that's just starting. Again, that disappeared when the variants changed, but this was something we found. So we published this. Somebody else send you the links so we can circulate with the group. But so in this case, user-generated data gave us a very significant clinical insight that actually wasn't available in any of the professional setting care that we were receiving. People were talking about it as they're trying to take care of COVID themselves and actually voicing and trying to understand this condition that they have. So loss of smell and taste, again, picked up through what patients were talking about. I'm going to quickly cover a follow-up that we did to this as well, which was, as you recall, I said, once you've identified a person, you can actually then follow their journey. And what we were concerned with a few months later was around kind of the persistence of conditions after recovery. We actually had teammates who had long COVID that were really suffering, but we were also just generally interested in how long does, once you've stopped testing positive, how long do the symptoms persist? And what are they? Again, we're not really good at tracking those issues longitudinally in professional care settings, because once you're fixed, you're not a problem anymore. We move on. And that's where a lot of self-care happens, because symptoms could continue. You might have headaches for months and you're just popping Advil and hoping it goes away. So this time we went to Reddit, and again, we use an active learning framework to identify people who who tested positive for COVID, who then recovered. And then we collected their posts around that period, before and after that recovery. We also used NLP to tag physiological and psychological symptoms separately, and kind of looked at how they evolved. We had about 2,200 posts, I believe, that we were able to kind of review. So what we were able to see was this very interesting piece. So 54% of the symptoms that we saw during testing positive to not testing positive anymore segment, there were just these acute symptoms that we would expect them to go away, very much associated with general respiratory problems, body aches, cough, etc., fever, that have, we know how to treat them. But what was really interesting is that symptom profile shifted after recovery, as you would expect, but shifted heavily towards psychological symptoms. And so a lot of the other symptoms that disappeared, they got replaced by people who had long stretches of psychological symptoms after recovery. And they were looking for help on those symptoms in these patient forums. Again, we were able to see how long these symptoms persisted. Again, in our sample data, we can see that on average, you're talking about 45 days of symptoms after you stop testing positive. This is a very long period for anyone in full stop. But if you have dependents, if you have other responsibilities, this is a period where you're really still under the weather and trying to go through life. So what we were able to find and start kind of teasing apart after this work was, what are the mental health and wellness supports that are needed post-COVID recovery? Because it seems to be very persistent. And kind of we've used this to work with actually a number of kind of not-for-profit organizations to see what supports could be mobilized. Yeah.
And then rainfall.
Yeah.
People could not go around with they have.
Oh, absolutely. Like I said, I had coworkers who had this, who just became different people overnight. And there's a difference between, this is not work we did, but if anyone wants to do it, you should. There's a difference between persistent symptoms after recovery, which is, your body just went through a pretty bad ordeal, versus things that are going to last for months, because I believe long COVID is months and months and months. And there's actually different potential treatments depending on what you have. Sometimes actually a vaccine could be a solution, which is interesting. But yeah, again, going back to where I started with my triangle, that's 45 days of self-care that we had no data on and that we weren't doing anything about, because we decided, now that you're testing negative, we don't care about you. You can, go to Shoppers and deal with it, but you have to actually care for yourself. So all these two examples, what I really want to highlight is that, yes, user-generated content usually used for marketing and behavioral studies, but it's actually could be a goldmine for also clinical insights. And clinical insights for parts of the health journey that reside outside of the standard health system. And again, from an innovation perspective, it's really important to understand that whole continuity of the experience, as opposed to just focusing on, let's say, a clinic experience or a therapeutic experience. Now, over the last 12, yeah, go ahead. Of course.
You're looking at that. Well,
yeah.
I would more of all the people where they must like see different kind of symptoms. And
yeah.
They might be actually more physical.
Yeah.
So it's interesting in using this type of methods is, again, it's an important population, but we're missing self-healthcare for very critical population because they might not be as.
Of course.
Yeah, but this is a whole personal thing.
Yeah, there's huge bias.
I want.
I mean, I'm not posting about COVID if I'm there. No, there's huge bias in the data. There's a way to kind of start splitting it by people who are there because they're caring for someone and trying to navigate their care versus themselves. But I 100% agree. I have a slide after this, but why don't I hit on that now? One of the ways that we use this is to actually inform additional primary data collection. So what you can do is, hey, here are the signals I'm getting. You're going to understand different outcomes that you're going to be interested in, and maybe sub-demographics that you might want to go after, and optimize your primary data collection with these insights. And then the other thing you can do is, once you have your data collection, you have some insights from the primary data collection, you can also confirm and see if you're seeing some confirmatory user-patient conversations that kind of generalize it. The nice thing about this is you can also be language blind. We've done this in various languages, especially relevant in parts of the world where there are multiple languages being spoken. A lot of traditional research might not go into those other groups as well. At least this way you can see how things might be manifesting differently for different people. And on that note, one thing that's completely changed the game and made all of our investments in the pipelines that made all of this work super, super easy is generative AI. So we had a beautiful pipeline that could go into any user-generated content and start tagging it for clinical insights that we had spent lots of time building, and then GPT came along and ruined it. So the beauty of this is we built a new pipeline in 2 weeks that works better, and and it's cheaper, so much cheaper. So the reason I'm saying this is it's actually so much easier to do this work now, where you can the whole active learning piece. In all of the work I showed, there were human verifiers that actually went through. It wasn't just blindly trusting AI and tagging things. But honestly, it is just so much easier to do it with a data pipeline, with an analysis pipeline that has GPT in the middle. It's so much better at understanding what's good, what's not, and then kind of propagating it. It's so much better at multiple languages and understanding nuances in even different dialects of the same language. So the game has changed. So what I showed you was, we're really proud of the work we did then, but it's actually kind of significantly easier that you could do it as a class project, and maybe you should. So, how much time do I have left? Okay, maybe 5 minutes. I'm going to skip over a few things. Again, I think, what are some of the takeaways? A, use this if you can. There's a ton of insights out there. Is it going to deliver beautiful solutions like smell and taste, like it did for COVID always? No, but you won't know until you try. Like I said, I've been working a lot on hormonal health space. I was using a similar approach for polycystic ovary syndrome. Just from the first look, I had 750,000 conversations that I could mine. Should I not go into that because that's not clinical data collected by a hospital, or should I actually be investigating it for clinical insights? Yes. Yeah. Yeah.
I'm just wondering how much are we these other, and would that be considered, user-generated content in some ways, because it's, or, how do you integrate other user systems like
No, absolutely. So there's actually a ton of data on consumer purchase behavior. If you collect Aeroplan points, great, we have your data, it can be purchased. Yeah, you can definitely overlay that, especially if you're looking at a longer time span, where you're looking at maybe changes in either clinical changes or behavioral changes in patients. You might overlay that with consumer behavior to see if there's actually other external factors that are influencing that. People will talk about it for sure, But yeah, you can definitely bring those consumer trends in. For example, I think I mentioned that earlier, things like at-home STI testing, at-home kind of fertility solutions or birth control, etc. Significant changes in the US after last year's events. And the first thing you saw was in the consumer side of things, not in the traditional medical space. So again, absolutely true. Going back, a lot of healthcare is self-driven. Well, a lot of what we do is consume things, and it reflects there. Yeah. 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 Mm-hmm. Mm-hmm. The global mass event. Yeah. I mean, for sure. And that's why I kind of threw up this example of PCOS. Again, that is a condition that isn't triggered by a global infectious kind of context. But again, it's a chronic condition that requires a lot of self-care, and it's represented in user conversations. Again, like I said, from last year, I found 750,000 conversations on PCOS. So. Yeah. All at once. Yeah, it's true. Well, there's no limit to the amount of user content you can scrape if you're willing to pay. So you can kind of expand your data collection period to 5, 6, 7 years and try to capture patient journeys through that period, as opposed to kind of looking at March 2020 in the case of COVID. So you're able to find those journeys at the user level. And the nice thing is, because people identify themselves, you can actually track their journey separately from my journey, separately from Sumaya's journey, and then see the overlaps.
But it cannot be data to be learned by.
Yes.
It cannot be data still or.
No, absolutely. Yes, that becomes a much, yes, creating those data sets that then you can mine for these insights is obviously harder for rarer events that have, conditions that have been going for a long time. Yes, that requires much more data engineering to create a data set that's actually going to be useful. Yes. Yeah. Do you want to chat after the talk to dive into that? Yeah. And with that, I think I'm almost at time. So in conclusion, use it. Technology landscape makes it so much easier to use. And there's a ton of questions one could ask around where you might start, depending on your focus in healthcare, but it doesn't have to be healthcare. It could be other things as well. Thank you.
I'm still a little confused about the relationship between the industry animals that were attacking you in your PhD thesis defense, but I never mind.
Not the defense. Oh no. Oh yeah, we should talk about it.
That was lovely. Thank you very much.
No, thank you.
And I have at least one person who wants to know all about NLP. Try down that. Yeah, right.
Okay.
We'll get to that later.
I'll stick around for a bit if you want to have if you have any questions. But thanks for attending. Thanks for giving me your lunch. Not.
You're going to explain that, right?